let's take a quick look at our program objectives. First, we will explore research on trauma-informed practices that can help shape correctional health programs for women. Secondly, we will highlight models of correctional health programs reflecting both evidence-based behavioral health programs and effective OB/GYN health practices. Thirdly, you will learn how professional healthcare organizations contribute to correctional health care for women. And finally, you will be prepared to initiate conversations within your agency for creating and/or enhancing healthcare practices for justice-involved women. We'll take a moment and introduce them to you.
Bernie Isler is a correctional program specialist with the Academy Division of the National Institute of Corrections. Isler's projects include the Regional Training Initiative, Learning and Performance Initiative, and the development of the Individual Offender Intervention Program called Core Correctional Practices, to be released in 2014. Her passions include following the research on offender interventions and staff learning and performance, and using the science to create practical learning tools for the field. Wendy Williams has been the Director of Training for the Alabama Department of Corrections for over 10 years. She has over 25 years of experience working in the criminal justice system, with extensive experience in the education and professional development of criminal justice employees and offenders. Her passions include providing learning experiences that allow the learner to receive the vital skills and tools that are necessary to build a life and career that are successful and prosperous. She also strives to instill the passion for learning within all students and employees with whom she comes in contact. Mark Radcliffe is a Special Projects Coordinator with the Maryland Police and Correctional Training Commission's Correctional Training Unit. Mr. Radcliffe served as an instructor at the Correctional Entrance Level Training Academy in Sykesville, Maryland, and also serves as an NIC Regional Field Coordinator and Training Coordinator for the Mid-Atlantic Regional Gang Investigators Network. He is a certified instructor in law enforcement and corrections with the training commissions. His passions include officer safety and defensive tactics training for staff. Cindy Thacker recently retired as the Staff Development Director of the North Carolina Department of Juvenile Justice. For 27 years, Cindy led the development of new and experienced staff through basic training, educational assistance, leadership, and supervisory training, and the genesis of an intranet community portal for full-time and adjunct trainers. Thacker now works in curriculum development and facilitation with the NIC Academy and the National Partnership for Juvenile Services. Her passions include her own learning about the brain and how we learn, and using current research to inform best practices in curriculum development. Jim Wiseman is currently the Chief of Staff Training for the Missouri Department of Corrections, managing training for more than 11,000 DOC employees. He has worked in corrections for more than 28 years as a corrections officer, corrections sergeant, institutional training officer, academy training officer, and now as Chief of Staff Training. Jim is passionate about building partnerships with correctional leaders to ensure that training is not only seen as something that takes place in the classroom, but rather an opportunity to improve performance. Jim's tagline is, "If our staff aren't going to use the stuff we give them in the classroom, then why in the heck are we wasting our time training them?" Amanda Hall is a correctional program specialist for the National Institute of Corrections Academy Division. She came to NIC from the Indiana Department of Correction, where she was the Director of Case Management for adult institutions. She has worked in both juvenile and adult corrections. Her field experience includes programs, case management, training, and parole. Amanda is passionate about the professionalization of corrections. She believes the key is putting research into practice across all correctional disciplines. Ted Kinsler has over 20 years' experience in jail operations and training. He currently serves as the Training and Staff Development Manager for the Greenville County Department of Public Safety Detention Center. Ted's passion is to influence and develop people into effective leaders while encouraging them to create a successful vision of their own design. Margaret Davis is a consultant who designs and delivers training programs for juvenile and adult justice settings. Previously, she spent 31 years with the New York State Office of Children and Family Services, starting her career as a direct care worker and ending as Director of Training for Juvenile Justice and Child Welfare Programs. She is passionate about enhancing staff skills so that they can work effectively with their clients and enhance the likelihood their clients will succeed.
In a moment, we'll begin that discussion, but first I'd like to start with the objectives for this segment. First, we'll describe how the public health care model can improve the health of justice-involved women. Secondly, we'll describe how the National Prevention Strategy and the ACE study can impact women's health issues. Thirdly, we'll demonstrate how cultural competency and trauma-informed care can be effective. And finally, we'll explain how a multidisciplinary approach to providing health care can be used for positive quality outcomes for justice-involved women. The National Prevention Strategy for Justice-Involved Women. Right. Can you tell us, what is the National Prevention Health Strategy, and how does it affect justice-involved women?
Well, the National Prevention Strategy is America's plan for better health. And this plan was released in June 2011. And it was created by the National Prevention Council, where the Surgeon General, Dr. Regina Benjamin, is the chair. And it included members from the private sector as well as the department heads of federal agencies, 17 in fact, and the Department of Justice was involved in that. And the purpose of the guide is to improve the health and the quality of life of all Americans, which would include the justice-involved women. And our Surgeon General, she states that we need to change and place our focus on preventive care instead of sick care, and that we can do in the correctional environment.
Healthier people and fewer costs for doing
Yes.
that. The National Prevention Strategy has 7 priority areas. Can you highlight what those areas are for us?
Yes, they have the 7 priority areas, but they also have 4 strategic directives that the council had developed. And the first directive is build a healthy environment, a healthy and safe environment for the community. The second planned directive is clinical and community preventive services. And the third directive involved empower people to make healthy choices. And the last directive was eliminate health disparities.
All right, and within those recommendations, there are the 7 priority areas.
Yes,
All
now
right.
we have the 7 priority areas that are in the directive. We need to have a smoke-free environment, was the first priority. The second priority involves preventive drug abuse and excessive alcohol use. The third involved healthy eating. And the fourth priority is active living. The fifth priority is injury and violence-free living. And the sixth priority is reproductive and sexual health. And the last priority is mental and emotional well-being.
Let's take a moment in our discussion to listen to Dr. Newton Kendig, who is the Assistant Director of the Bureau of Prisons Health Service Division, who talks about the application of this national prevention strategy nationwide throughout the Bureau of Prisons and the advantages of using that healthcare model in corrections.
The Surgeon General's National Prevention Strategy was really a landmark document for the United States. For the very first time, all Americans have a blueprint for better health and wellness, and I truly believe this applies to the correctional setting.
Let's talk about a couple of other terms, gender identity and sexual orientation. Again, a lot of times we think those are the same things, and not necessarily.
Right, that's another great one to pull apart. So you're right, they're not the same things. So when we're talking about sexual orientation, we're generally talking about the direction of someone's romantic attraction towards another person. We're talking about heterosexual, lesbian, gay, bisexual, folks who have a romantic or emotional attraction towards either the same sex, both sex, opposite sex. So that's, everybody has a sexual orientation, everybody has a gender identity.
But some other key areas have to do with, first and foremost, establishing a vision and a mission statement for the institution that is focused on the needs of women. Warden Patterson mentioned that earlier today, how important that is. And taking the steps to ensure that the staff in the facility are involved in the creation of that mission and vision statement so that they understand what it's about and they have buy-in to those principles. And then the next thing that I think is essentially important is knowing the population. And we've spent a lot of time today talking about this population, but it's critically important that all of the staff in the institution also have that same knowledge base. Through training that is dynamic and ongoing. It's not just enough to have orientation training for new staff that will be working in the female prison, but we have to have ongoing training that is current, that is appropriate, gender responsive, trauma informed. And then finally, it's critically important that we arm our staff with the tools necessary to really effectively engage and work with this population.
Given everything that we've talked about in earlier segments with all the trauma and all of the areas of trauma, abuse, and some of the risks and needs that we need to be aware of for developing some of these trauma-informed, gender-responsive programs, it seems to me that some administrators and people on an operational level may think, oh my gosh, we need to do a major overhaul of what we're already doing for women within women's corrections facilities. And I wonder if you can comment about that, Kevin, in terms of what you see as some first steps or some key areas that administrators should focus on.
Yes, right off the bat, it's not a major overhaul. And I want to key in on what Donna had mentioned regarding utilizing staff from every discipline in the decision-making process and when you go through these gender-responsive, trauma-informed processes. You should review your internal policies and procedures. Was one of the things you should focus on, as well as the programs that you are facilitating at your facility, making sure that they're both effective and they're meeting the needs of the offenders. The other thing that you should do is assess your staff, knowing their strengths and weaknesses. Anytime when you're trying to promote change, you need open staff, and we gather that through training and knowing who our staff are. You would always want to be a coach. Being a coach or mentor per se is an ongoing process through this venture, and always lead by example.
Okay. So the other question might be, what does it look like operationally as you begin to implement these gender-responsive, trauma-informed practices, procedures, policies in your facility? We have a great example of a promising practice. You've heard from Warden Mark Patterson earlier in the program. He's the warden of the Women's Community Correctional Center in Hawaii, and he explains how he creates what he terms space for his successful programs. Let's hear what he has to say.
When people ask me, what does a trauma-informed care system look like? I tell them, well, it's not as complicated as you think. Yeah? All I'm doing is trying to create space. And I explain it like this. SPACE is an acronym. Yeah? So I tell them, if you take the S, yeah, S stands for staff. Yeah? When you look at staff has to be trained in something we call Trauma 101, so they understand what trauma is.
So we're going to hear from a few correctional leaders who talk about the advantages of making partnerships inside and outside of corrections. Let's hear what they have to say.
I haven't found any system that doesn't have the opportunity to work with partners in the community and to really partner within your own agency with different functional areas such as medical and mental health. So the word partnership is really kind of loaded in women's services. But it's even more important in this environment because resources are shorter and slimmer. And so we really can't do our work alone. We can't do reform in the dark. I think that those systems that experience the most success have found ways to really leverage the benefits that partners bring.
In the 12 years that I've been with the department, I've noticed an improvement in health, an improvement in attitude, and a willingness to try with innovations and creative ideas, thinking outside the box, looking for partnerships, cultivating those relationships with your partners in the community and in the Department of Health and with other entities for grant opportunities, looking for partnering. With the economy the way it is and everyone's on the budget crunch, you really need to reach out to your partners because remember, they need you too. They need you too. In order for their grants to continue, they need someone on the other end to receive the service. And so it's a win-win for everyone.
Let's talk a little bit about mental health issues, which is also part of the whole medical evaluation. Caleb, what are some of the considerations for mental health issues related to LGBTI offenders?
Well, the principles are very similar from medical moving over into mental health. You want to provide individualized treatment. You want to assess each situation individually. One of the things that I think it's important to stress to agencies is to involve your mental health practitioners very early on in the process. And so from screening on into other interventions, when you have decisions to make around how operationally to work with a transgender individual, for example, keep mental health in the loop and continue to collaborate with your mental health providers. Make sure that you don't just make assumptions about that the person would have GID, gender identity disorder, or that they would be a sex offender. And also there sometimes is a concern or a fear that the offender is kind of manipulating the system when we're talking about transgender issues. And so that's where mental health can be very helpful for someone who you may feel like is maybe not being genuine in how they're expressing themselves. That's not for an officer or an administrator to decide. That's really for your medical and particularly your mental health. There are also programming options that we kind of want to stay away from, which are options that try to change a person's sexual orientation or change a person's gender identity. There's a growing body of research to say that those efforts are actually harmful rather than helpful. And so for administrators who are trying to help their mental health practitioners be more informed, they want to keep that in mind.
As I mentioned, what we're trying to do is take the information that we've gained from ACE and also from the National Prevention Strategy and begin to look at how we can improve the practices that we typically have in corrections where healthcare for justice-involved women is concerned. And one of those areas that we might want to look at is what tends to be the solo episodic approach to medicine. And you mentioned that earlier, Decorah, in treating justice-involved women. And Diana, can you talk a little bit about that and how that typically looks in some institutions?
Well, the type of healthcare that tends to be, it's not patient-centered, it's not gender-responsive that we've talked about, culturally competent, and it's not understanding or looking at the experiences that women may have been, gone through prior to being incarcerated.
We have a vignette that we'd like our participants to take a look at that in some ways gives you a little bit of a snapshot of what some of this solo episodic type of approach to medicine might look like. And can you set it up for us and ask our viewers for what they might be looking for in this vignette?
Just what I had mentioned, is the provider, who is the provider focused on? You know, who is the provider focused on? What questions are they being asked? Are they just making assumptions? Or are there other things? Are they more worried about what's outside of the exam room rather than what's inside the exam room and the patient before?
So let's take a look at the vignette and ask yourself, have you seen this kind of care within corrections for justice-involved women?
Inmate number 678012, I see you're here for a pap smear today. You're not dressed. I don't have much time.
I don't need a pad smear. What's a pad smear?
Yes, you do.
Why?
We have to perform one on all females.
What is it?
It's a cervical cancer screening test. I'm sure you've had one before.
I don't need one. I don't have sex.
Yeah, I'll bet you do. She's lying.
No, I don't need a pad smear.
Then sign this paper. You can refuse if you want. Just to let you know, you could die as a result of cervical cancer. All right, take her back. We're done here. Another liar. Glad she refused.
Takora, I'm wondering about your initial reaction to this exam and what you see happening there.
Well, I'm not sure I would want him to examine me.
We're going to go over to the chat desk with Marion and find out if there are some compelling questions and comments coming in on the online chat. Marion, how's it going?
It's going great, and we have a question about one of the things that Erica mentioned. One of our viewers wanted to know, what can a staff member do if they encounter an LGBT inmate, and how do they go about asking what you said that they need to do in terms of getting that information in a way that is respectful?
Okay. So I would say asking the person respectfully, politely, non-judgmentally, how do you identify? What terms would you like to see used? Do you have a pronoun preference? And I know that might be really pushing the envelope for some standard practices, but we are seeing jurisdictions develop a preferred pronoun list for someone that comes in and his name on the books is Daniel and would prefer to be called Danielle and identify as a woman. Like asking them what pronouns they'd like to have used, what name they'd like to be called by.
So rethinking the way that we communicate with and about LGBTI populations is really important. Marion, do we have any other questions or comments that you think are worth highlighting?
Yes, actually the definition issue, and people are wondering what are the best ways to get a grasp of the definitions? Are there things that can be done to help in regard to working with your colleagues, your supervisors, your peers to address this? What recommendations do you have for that?
Yeah, because clearly this is going to be a learning process, and it seems to me that it's not just handing somebody a set of laminated guides. It's part of a conversational issue, it seems to me.
Mm-hmm. And I'd say do your own work. Like if you're a viewer that's watching this broadcast, don't wait for the policy or the next best training. Like ask, if you know people that have an identity, ask them, talk to people in your own social network, in your own family. Get out to trainings, look online, read the participant, and don't stress yourself out that you have to have every term absolutely perfect the first time.
Well, and I think it's important too to remember that NIC has determined that these are the definitions that we're using for our purposes. Mm-hmm. However, there are many other definitions out there on the internet, and we're not trying to imply that ours are the best, but these are the ones that we have chosen to use.
Okay, so we have time for one more question, and I'm told we have Teresa on the line from Atlanta. Teresa, welcome.
Yes.
Do you have a question or a comment?
I have a question.
Okay, go ahead.
My question is, how do you tell at what age a youth is actually gay? And my other question is, are they born gay, or is it just something that, the chromosomes or something when they were born or were different? I mean, how do you determine that?
Mm-hmm. Thanks for your question. I know that we're going to be dealing with this a little bit more in depth, Teresa, later in the program, but why don't we give a short answer now, and this is part of a more in-depth discussion later. So let's give a short answer now to those questions.
Yeah, I know Laura's going to talk about that later in the broadcast, but we're seeing kids develop a sense of gender identity that might be different than their birth sex, sometimes as early as 3 and 4, and then develop feelings of romantic or emotional attraction, sometimes to the same sex, as early childhood, you know, like 10-ish even.
And Lori, what about the question related to born gay, the short answer?
Well, I think there certainly is some compelling research coming out of the medical and mental health community that says that this is an immutable characteristic, that it's not something that can be changed, and that it is something. I know there is a lot of controversy about this being a biological issue as opposed to a choice issue, but really the emerging research is telling us that it is something that people come with.
Why is preparation an important step in the training process, Rob?
Preparation, Wendy, is an important step because that is what you're your training and the preparation that you do to get ready for the training, you're going to carry that through to your job performance in the end, to your end product. One of the things that I learned early on in my career is that when it all comes down to it, when things get really bad, when we have a critical incident occur and you're in the heat of the battle, you always fall back on your training. You go on autopilot. The only way you can fall back on your training is to be prepared and receive that training and use those tools that you've learned applied in the field. I think preparation, well, like Benjamin Franklin said, to prepare or to fail to prepare is to prepare to fail. That is so true, and I think that carries clear through to the job.
Great points, Rob. Anyone else? Deputy John Oliphant from the Training Coordinator, Spokane County Sheriff's Office.
Yeah, thank you. It's important that we realize, and you know, I've been working in our training unit for about 5.5 years now, and it's important that we realize the responsibility we have on ourselves as coordinators, as administrators, as those responsible for setting up the training for our troops, that we do prepare adequately, so that the training that we present is effective, it is powerful, and it hits home the learning objectives as much as they possibly can, so those guys and gals can take the training back to their workplace.
Okay, what a great discussion. And so at this point, we've actually looked at the agency's role in preparation for training and how supervisors can get actively involved in that process, as well as what we as trainers do, and what a great bit of expertise we have here in the room and the comments that you shared, and then also how the learner can take part in that process. So what we want to do now is give you an opportunity to practice some of the things that we've talked about and take a look at those lesson plans that you brought with you as part of the pre-work for this event. We're going to get our off-site audiences involved again. We're going to have 5 minutes in our groups here in the studio, as well as your groups out there off-site, to look at those lesson plans for ways that you might incorporate some of the preparation techniques that we've talked about here today. Our in-studio audience is going to chart some of their responses and share that with the entire group, and we hope again we can get some of our off-site audience participants on the phone or emailing in some of your feedback to share with us as well. Again, we'll have 5 minutes. So those folks off-site, you want to start calling in when that clock starts ticking down. We'll see you shortly. So let's check in with our probation and parole staff from the Idaho DOC at Table 2 and see what they came up with.
A couple of things that we did was we made it very specific to weapons training within our department. I think the initial thing that we talked about was the buy-in, making it convenient for everybody so that everyone wants to come to the training and attend the training. So we're going to make it convenient for them by offering different dates and times for the training. Another part of importance was the policies, making sure that everyone's aware of the policies prior to the training, the safety rules, and the equipment expectations of what to bring and what not to bring to the training, such as live weapons, not to bring those, and know what to expect prior to getting there. Again, making everything, giving it out in advance also allows time for everyone who has questions and hopefully time for the instructors to answer those questions prior to the training.
And so we're going to do another activity. In your participant guide, page 31 and 32, we have examples. One is an example of a stair step and one is an immersive. And what we want you to do is identify which plan works best for novice and experienced learners. And here at the tables, you can have a discussion at your tables, and out in our audience at your desktop or in that group, we want you to look at these two and have a discussion about which one do you think would work best for novice learners and for experienced learners. Thank you. Okay, we're back. And to debrief this, Cindy's going to work with us.
So we're going to go to Margaret and see if we got some responses on live chat.
Yes, Kathy had a really good point. She said the first one was stair step for our novice learner, which really provides the basic information. The second lesson outline was for the more experienced learner. It also provides the basics, but it allows the participant the opportunity to provide insight and possible updates to the lesson plan itself.
All right, that sounds good. Now we've got a caller. We've got Michael from Alabama. Michael, what were you thinking?
Well, we looked at both of the outlines and we kind of felt that the first one would be for the novice learner simply because it is a step-by-step process. It gives them a chance to not only digest the information, but it also gives them a chance to build on what they learned initially. And then looking at the second outline, I think it addresses the issue of complacency with maybe the experienced learner because it gives them more hand-on.
Okay, so they don't get complacent because they have something to do. They actually have to do some stuff. Good input. All right. All right, let's talk to our folks here in the studio. I think Amanda, did you have a comment on this one?
Well, I agree with the callers. The first one was for the newer learner, the stair step learning, and then again with the second one, it's more for the experienced learner. So.
Okay. Was there anything in particular about the one for the experienced learner that made you think that? Is there any particular characteristic of it that kind of stood out?
I think with closure and evaluation, conduct simulation of effective fire extinguisher use. That hands-on reality experience really helps with the experienced learners.
Okay.
So.
All right. How about this table? I think Becky?
Yes. We agree with the callers and our cohorts here. The first one was very instructor-driven, very basic, very structured and supportive by the instructor. The second one, obviously for more the experienced person, is more student-driven, maybe even co-partnered a little bit, more advanced and practical. And then again, I agree with Amanda on the closure and evaluation part is more trusted practical exercises. You're not just going to hand a fire extinguisher to a novice and say, show me how to work it out. So.
Okay. Before we go to the next table, I think we've got another phone call from Deborah in Delaware. Deborah, tell us about your use of these outlines.
I agreed with the previous caller. The first one was more for novice and the second one for advanced. But my question to you is, Would there be an appropriate time to use the stair step to teach a more advanced skill for your experienced learners?
Yeah, that's a really good question, because we're really talking here about people that maybe are in basic training versus in service, but there's another way to look at this, which you could have experienced learners or experienced staff who are being presented with brand new information that they've never had before. Because we don't, just through experience, we don't learn everything. So there might be a new policy, the law might have changed. There might be a number of things that you're really seeing it for the first time, even though you're an experienced staff. So I would say, yes, you'd go back to the more stair-step type of architecture, although you might still want to take into account that these people have some experience that maybe you can incorporate